Thank you very much that you all given your valuable consent for this wonderful webinar on Netalo. As you know, Ajanta always believe in launching newer and newer products. So it's a very auspicious day for all of us that we are doing the second launch webinar for our Netalo, that is Nitarsodil. I am sure this session is going to be quite interesting. Without taking much of time, once again, thanking each one of you for joining this program. And I am handing over this session to Dr. Rajul Parikh, who will moderate this session. As
Yeah.
regards Dr. Parikh is concerned, there's no introduction required. He is a known figure in the glaucoma world and in ophthalmology itself. So over to Dr. Rajul Parikh. Thank you so
Yeah,
much, sir. Please.
thanks, Mr. Manoj. So, good evening, everyone. This is going to be a very interesting session. The paradigm shift in glaucoma management, and what we have tried to do that Dr. Deepak Adverb is going to talk about the Netrasodil in great depth. Shefali is going to talk about the nanotechnology, these two new aspects of the glaucoma management. At the same time, we have tried to keep the balance. So Dr. Chandrasekhar will talk, because whatever said and done, the principle, the philosophy of glaucoma management is not going to change in a near decade or so. Something drastically neuroprotection come, till then the philosophy more or less will remain same. So Dr. Chandrasekhar will talk about the philosophy of glaucoma management. Then angle closure glaucoma is a big problem in Indian subcontinent. So Manish will talk about that. And as we know, then from various population-based study, including Indian study, that nearly 50% of the patients' pressures are less than 21 at baseline. So we should not forget the normal tension glaucoma. So Sunita will talk about that. And then we'll have a question answer. So whatever question answer you want to ask based on the talks or without the talks, you can just pass on the chat box, and we will have that question answer at the end. Now, Dr. Deepak Adverb, Dr. GC does not require any introduction, but as a formality, I must introduce them. So I'll just share my slides. So Dr. Deepak Adverb he has done residency from PGI Chandigarh, but currently is a vice chair education professor of ophthalmology at Chicago. He's a very well-known entity as glaucoma world is concerned. He has more than 200 publications. He has several teaching awards, and including his innovative educator. So he is one of the best glaucoma specialists at this point in time. Dr. Chandrasekhar, in India and abroad, he doesn't require any introduction. He is vice chair of LU Prasad, and when I joined as a faculty in LU Prasad, he was a head of department. So I worked under him for a very long time and learned a lot. And then along with these two, we have three eminent glaucoma specialists: Manish, Sunita, and Shefali. Manish and Shefali are in Mumbai, and Sunita is from Delhi. So all three have huge clinical experience. And Sunita Shefali also have publication, academic experience also. So we'll have a great the world glaucoma leaders and eminent glaucoma specialists from India. And I hope that this session is going to be a very interesting thing. I will request Dr. Chandrasekhar to start his presentation. Sir, please.
Thank you, Rajal. So the customary beginning. I hope my slides are visible and I'm audible for this Zoom. Okay. So in the next 15 minutes or so, what I'll try and do is share some thoughts on broad principles of management of the glaucoma. Obviously, the way the talks are structured, I will restrict my presentation to primary open angle glaucoma. So when we talk about the philosophy of management of glaucoma, I think we need to talk about diagnosis. And in the context of diagnosis, are we trying to diagnose a very early disease or an established disease? And the concept of prior probability when we use the imaging technologies. And when we talk about progression, which is the other paradigm on which our decisions are based, we need to understand what's the natural course of the disease that we are trying to treat, differentiate between a rapid versus slow progressor, and then finally some management treatment decisions. I'll give a paradigm towards the end of my talk. So beginning with the diagnosis, of glaucoma, early versus established. I'm not going into the details, but I want to touch upon the concept of the imaging technologies that we are very fond of. In one of the talks that I gave probably a decade ago, the talk given to me was early diagnosis made easy. And I guess the thought process before with the organizers was that we have so much of technology, so we can probably diagnose very easily. I think that's a myth. The thought process that we are having an objective test, we tend to deal with uncooperative and illiterate patients. Visual fields is time consuming, and our new technology actually measures the nerve fiber layer thickness. And we keep reading that 20 to 40% of ganglion cells are lost before a visual field defect is developed. And we're using the state of the art technology will actually all put us into a false sense of security when we are using these imaging technologies. From that perspective, I am fond of quoting this article. This is a cardiothoracic journal, and I will read out the quotes from that. The bottom line is this: while modern medical technology has greatly enhanced our ability to diagnose and treat disease, it has also promoted laziness, especially mental laziness, among many physicians. It goes on to say, habitual reliance on sophisticated medical gadgetry for diagnosis prevents physicians from using the most sophisticated, intricate machine they will ever and always will have, their brain. So my argument is for using your brain more productively. If you're using these imaging technologies for an anatomical change like a macular edema, they do a great job. But we are trying to look at the nerve fiber layer thickness and trying to correlate with what happens in the so-called normal population and use a lot of statistics. That is where we have the difficulty. So as an example, this patient had significant loss of nerve fiber layer as shown by the OCT, and he was told that he was going to go blind in 2 years. And these are his visual fields over a period of time, which did not get affected at all. So that's the kind of false positives that we will have. The fundamental point that we need to remember is that in the context of making an early diagnosis of glaucoma with a very minimal field loss, with a very subtle change in the optic nerve fiber layer, this is the area where we may need the imaging technology. Hopefully, when the disease is established like this, the imaging technology may not be needed. But even then, if it is needed, one needs to remember that it is only one hemisphere that is predominantly affected. If we need imaging technology to make a diagnosis at this stage, we need to probably repeat our residency once more. So with that point, the concept that I want to drive home is this. All of us have made the statement that this was bound to happen, and that is impossible. Whether it comes to the share market or whether it comes to somebody that in the college that we see going, young boy and girl going together, getting married, all these real life situations, we know that something is bound to happen and we know that something is impossible. This is because of the incremental change in the likelihood of that thing happening. And this in mathematical terms is called Bayesian prior probability. What I'm requesting you to do is to use the same logic when you make a diagnosis. As an example, if you have these changes of an ischemic heart disease in a 25-year-old possible army recruit, the question you will ask is, how old is the machine? Who is the technician? But if the same ECG printout belongs to somebody who is 70, has diabetes and hypertension, you are asking where is the nearest cardiologist. The image, the printout of the report did not change, but the clinical context in which you are looking at that has changed. So if you have a disc like this, which looks relatively healthy, and a disc like this, which shows clear-cut notching inferiorly, then the possibility of disease is very low here, and the possibility of disease is very high here. Only when the possibility of disease in the intermediate range of around 50%, a positive diagnostic test will increase the result, the diagnosis being positive, and a negative diagnostic test will rule out the disease. But in this situation, even if the test is negative, it cannot rule out the disease. In this situation, even if the test is positive, it cannot rule in the disease. We need to use the rest of the clinical picture. What do I mean? As an example, look at this visual field. There is a superior central scotoma and a nasal step that is suggestive of glaucoma. I scratch my head to look at the disc multiple times. I cannot make out a correlating inferior neuroretinal rim change or a nerve fiber layer defect. Then I go to imaging. Though the averages are normal, I find a nerve fiber defect in the inferior arcuate area that correlates with the visual field that I've seen. So in the early diagnosis of glaucoma, what I see correlates on the imaging, correlates with the visual field defect that I've seen. As opposed to that, this is a different example where you have, this is what the Humphrey does for us now. The red of the imaging technology and the black of the visual field defect are put together. So here you have a superior nerve fiber layer defect and an inferior field defect. They correlate with each other. So they're true positives. As opposed to that, this disc looks relatively healthy. On the imaging, you have everything red, but the visual field is completely normal. So that's why this is a false positive. So that is the kind of correlation that we need to do. Having talked about the diagnosis and not getting misled by the technology, I will move on to talk about what is the natural course of the disease and how do we differentiate between rapid versus slow progressors. This is a beautiful publication from Moorfields. They have looked at the disease progression in the clinic over a period of time and extrapolated what happens with the same rate of progression towards the whole lifetime of the patient. And a large population of clinic-based data was seen. And this is what you see if it is extrapolated over a period of time. All the blue dots are the ones where the visual fields have improved over a period of time. The green dots have progressed but did not develop a visual disability. The yellow dots progressed and developed a visual disability in the better eye. And the red dots are the one that became visually blind, very advanced disease. So the number of eyes that go into advanced disease are very small. And there are significant numbers that progress but do not get affected, and a large number that also actually improve over a period of time. So the data that came out from that publication is from their study. It's only 3% that had a progression rate of more than 1.5 decibels per year. And the visual impairment was seen in 10% and blindness was seen in only 5%, according to that data. What is important is that more than 90% of those that went blind actually had a visual field defect of more than -6 decibels in at least one eye. So this aggressive early diagnosis based on the imaging technology, I think is a no-no for us if you want to be safe to our patients. This is the data from my own practice some time ago. A significant number of patients that you see below the zero line are patients who are improving. A large number of patients probably progress but do not progress rapidly. A small number of patients have a very rapid visual field progression, and our diagnosis and management are going to help these patients and probably not affect those patients that much either way. One more recent publication, you see a significant number of primary open angle glaucoma, angle closure glaucoma, and normal tension glaucoma. All those to the right of this vertical line have improved over a period of time. All those to the left of this vertical line have deteriorated, and only a smaller number actually progress very rapidly, and many of them progress very slowly. This is the data. 14% of hypertension glaucoma, 13% of angle closure, and 14 to 15% of normal tension glaucoma progressed at rates greater than -1 decibels. And 1 in 5 to 1 in 3 actually improved over a period of time under treatment. We have similar data from the early manifest glaucoma trial. People with pseudoexfoliation and relatively elderly age go from normal visual field to total blindness in less than 2 years. People with normal tension glaucoma and relatively young in that cohort actually do not progress to blindness, even if not treated throughout their lifetime. So this difference is what we need to remember and actually look for progression rather than just presence of disease. Having said that, I'm not undermining the fact that a lot of glaucoma patients go blind. This is data from our secondary centers. Over a period of time, the number of glaucoma patients of the total cohort that attended the clinic was about 5%, and anywhere from 10 to 20% actually presented with one eye being completely blind. So in the community, there are a lot of people who are going blind who need treatment for whom we are not available. But in the clinic, we probably end up treating aggressively people who may not need our treatment. How do we judge progression in a clinic? We have to go by the so-called visual field index. And in the visual field index, you see what is happening to the patient over a period of time. It is these patients like this which have a rapid progression. Once we intervene and do a surgery, their visual field progression becomes stable. Another example of a patient who is progressing rapidly in one eye and progressing very slowly in the other eye. It is these patients that we need to be aggressive about. Then moving on, talking about some management decisions. Our job is to establish progression and pick up those rapid progressors, differentiate between IOP dependent and IOP independent factors. What's the risk of visual impairment for that patient during his lifetime? And what's the risk benefit of the intervention that we have in mind is what we need to see. It's a very beautiful editorial, one of my favorite slides as far as the philosophy of management glaucoma is concerned. There are patients of glaucoma whose optic nerve is highly sensitive to the pressure-induced damage, and there are patients whose optic nerve is not sensitive to pressure-induced damage. There are patients who remarkably respond to the treatments that we give as far as the pressure lowering is concerned. So it is these group of patients who respond very well to pressure lowering therapy and their optic nerves are sensitive to pressure-induced damage that actually benefit from treatment. It is these group of patients whose optic nerves are not sensitive to pressure-induced damage and their intraocular pressure do not respond to therapy that we give, get only the side effects of our treatment, but no benefit whatsoever. Unfortunately, we do not have ways of differentiating these people from these people at this point of time very clearly, but we need to remember that fact that our treatment may not help some people. Some of the principles of management that we keep listening to is this is the first line of drug, this is the second line of drug. Start always a unilateral trial. Don't start more than one medication at a time. Establish that your medication is actually working by doing a unilateral trial, and so on and so forth. So all these things can be applied provided we have a patient presenting with an early disease who has a good compliance, probably progressing very slowly. On the other hand, if the patient has an advanced disease, possible poor compliance, rapid progressor, elderly age or young age with a lot of life ahead of him, the threshold for surgery in these patients would be very low, and we do not have too much time to play around with all the principles that we talked about in the previous slide like this. So that's the other thing that we need to remember. So with that paradigm, how do I go about treating a patient of open angle glaucoma? I will divide them that he is presenting to me early or a doubtful disease, presents with a very high intraocular pressure or a borderline IOP in the early 20s or a normal intraocular pressure. Presents with a very high IOP, I start the medical treatment, watch for control, follow up if the pressure is controlled. If the pressure is not controlled, then look for a secondary glaucoma and look for that cause and try to treat that cause. If I rule out a secondary glaucoma, then I will go ahead with surgery. Patient presenting with a borderline IOP, good intraocular pressure control, will follow up the patient. If there is no control, once again look for secondary causes. If the control is also borderline, then carefully watch for progression. If there is a progression, if there is stable disease, continue with the borderline pressure control. But if there is progression, then think in terms of surgery. If the patient has a normal tension, normal IOP, and you're suspecting disease, probably reassess the diagnosis. It may be a congenital anomaly, it may be a one-time damage, it may be a neurological problem. You're probably not dealing with glaucoma. If you're still dealing with glaucoma, you need to investigate for normal tension glaucoma that Sunita will be talking about. As opposed to that, if somebody presents with an advanced disease, high intraocular pressure, look for compliance and control, maybe start with more than one medication. My threshold for surgery is very low there. Borderline pressure control, advanced damage, watch carefully for progression. If there is a progression, surgery, probably surgery with a low target intraocular pressure. If it's a normal tension glaucoma, investigate, medical treatment, watch for progression. If it is not controlled, there is a justification for doing a filtering surgery with mitomycin C. I will close with one more example from the same philosophy that I talked about, hyposcilia. I fervently hope that current teachers of medicine can somehow recapture the Australian spirit and strive diligently to restore the very core of doctoring, humanism. How does it translate to glaucoma management if you're not careful about what we are doing? So this 49-year-old patient presented with glaucoma, had a YAC PI done, visual fields in one location, both eyes very advanced damage. A month later, advanced damage, visual field in a different location, has had a brain scan done. And by this time, the patient is depleted of the money that she has and she is in depression as to how can she take care of her family and so on and so forth. They came to LB Prasad Hyderabad. I looked at her. This is the drawing that I drew for her. That right eye has a 0.9:1 cupping with a bipolar notch. Left eye looks nearly normal to me. So the kind of visual field she has is because of the depression of the diagnosis that we have given her. Reassure the patient and repeat the visual field. Advanced damage in the right eye, but 10-2 is pretty good. The left eye, almost no damage, very early nasal defect. So how we diagnose the disease and how supportive we are to the patient is, I think, something that we need to learn and keep reinforcing. So I covered the natural course of the disease, stressed on the need for judging the rapid progressors. Be very careful and decide whether we are dealing with early disease or advanced disease. And our medical and surgical decisions and the way we deal with the patients and support them should depend on all these factors. Thank you for your attention. You're muted, Rajul. Rajul, you need to unmute yourself.
So, sir, it was a very nice talk, very illuminating. Is it okay if we take the question at the end?
Sure.
Huh? So the next talk is Sunita. She'll be covering the management of normal tension glaucoma. Sunita, will you take over?
Yeah. Can you see?
Yes.
Can you see my slides? Yeah. So
yeah, we can see your slide. Go ahead.
Yeah. I would like to thank Rajul and Ajanta Pharma for giving me this wonderful opportunity. I'll be talking on normal tension glaucoma. So as we know, NTG and POAG represent a continuum of open-angle glaucomas. While intraocular pressure is the predominant causative risk factor in POAG, additional IOP-independent factors, especially the vascular factors, are said to have a role in NTG. NTG accounts for a significant percentage of all forms of open-angle glaucoma, especially in Asia. In Japan, 92%, and in Baltimore eye study, 58.8% patients had intraocular pressure of less than 21 millimeter mercury on presentation. NTG may have subtle differences in clinical characteristics. The patient may present with focal rim loss, focal RNFL defects, and visual fields loss, which are dense scotomas close to fixation. And there are increased prevalence of disc hemorrhages. It's been said that NTG patients who present with mean IOP in low teens, that is less than 15 millimeter mercury, there is a possibility of having different pathogenesis and progression patterns. I would just like to highlight a few cases of normal tension glaucoma, which I have been following for quite a few years. So this is a patient, 45-year-old young patient who presented with blurring of vision. There was no systemic history positive. Vision was 6/6. IOP was normal. Gonioscopy showed open angles. And there was this superior RNFL thinning with the superior NRR thinning in the right eye with corroborative visual field changes. And similarly in the left eye, there was some thinning of the inferior rim with inferior RNFL defect. The IOP diurnal both day as well as with triggerfish was normal, and the systemic blood pressure was also normal. So we made a provisional diagnosis of normal tension glaucoma. Well, he didn't give any positive history of using steroids or migraine or Raynaud's phenomena or difficulty in breathing during sleep. And he was a very educated patient, and he got all the investigations done and nothing was positive. He showed some signs of progression after 2-3 years in the right eye, while the left eye was normal and non-progressive. So we just thought in terms of any vascular abnormality, and we just got his ambulatory BP monitoring done, which showed some spikes in the afternoon. And this color Doppler imaging, that time we had the facility available, we got it done, and there was slight decrease in the end diastolic velocity and increase in the resistive index, suggestive of maybe decreased perfusion pressure and of the optic nerve head. So this patient has been following up with us for the last 9 years, and the points which were showing initially, 2-3 points were deteriorating. were improved again, and there was just a variability at those points. So he was a very slowly progressive disease. He showed a very slowly progressive disease in the left eye. Last year he showed in 2-3 last visual fields, it shows some deterioration at some point with a possible progression. Next patient, again a young male patient who had a history of acute blood loss, and vision and IOP was normal, and he presented with these findings in 2003, and the corroborative changes in the optic nerve and visual fields. Again, the diurnal variation was normal, and systemically he didn't have any positive history, and we just thought it could be a non-progressive one-time event. And this patient has been following up till now. In 2019, although trend analysis showed a very slow progression, just 1.7% per year, but in event analysis, you can see these 3 consecutive fields are showing some deterioration at 2 points here, suggestive of likely progression. So in both eyes, recently after 14-15 years, he showed some deterioration in the event analysis. So maybe warranting some change of treatment. But again, this is a very slow progressing disease. The third patient gave a family history of glaucoma, and he was under antidepressant treatment, and there was no positive history of hypertension, diabetes. And these are the disc findings. As you can see, there's some RNFL defect in inferior rim notching in the right eye. In the left eye, it was normal, and there were changes in the OCT and visual field. So visual field changes were correlating with the optic disc changes, and he did show some sign of deterioration. So this is the diurnal variation, and none of the readings was high. So he had a history of disturbed sleep cycle, snoring, and excessive daytime sleepiness and fatigue. So this obstructive sleep apnea is the newly recognized risk factor. So we just asked him history, and he gave a positive history. So he was advised polysomnography. So it's an interplay of various risk factors, the IOP related and vascular risk factors, and there could be wider IOP fluctuations, especially during night, spikes of intraocular pressure, rise, and the other factors, thin CCT and East Asian ethnicity, or vascular factors which can lead to deficient blood supply to the optic nerve. So etiology of normal tension glaucoma possibly is multifactorial, and cardiovascular system and intracranial pressure may be involved in the main pathways of optic nerve damage. And various landmark studies have shown evidence for reduced perfusion pressure in glaucoma. The diastolic perfusion pressure of less than 30 millimeter had 6 times higher risk of glaucoma, and patients with low systemic systolic ocular perfusion pressure show an 50% higher risk for progression. So all these systemic conditions which are associated with vasospasm or endothelial dysfunction in some way can lead to auto-dysregulation and decreased ocular perfusion pressure. So a condition described by Flammer, who has done a lot of work on normal tension glaucoma. Obstructive sleep apnea, as I said, is again, it's a newly recognized condition though, but it is not uncommon to see patients, obese patients, who have recurrent, complete, or interruption of normal breathing due to functional occlusion or collapse of upper airway during sleep, leading to decrease in arterial oxygen saturation and rise in carbon dioxide during sleep, and leading to reduced perfusion pressure. So it's important to ask history of snoring or nocturnal gasping. Patient may complain of lack of energy, reduced concentration, dry throat on waking up, and morning headache. And it can be easily diagnosed by overnight polysomnography and apnea, hyperapnea index per hour. And CPAP does help these patients in improving their sleep pattern and improving the perfusion. So coming to diagnosis, NTG is the diagnosis of exclusion. You need to rule out the POAG because there could be nocturnal spike in some patients. The DVT, diurnal variation has to be done. One needs to check the central corneal thickness. And of course, one has to do gonioscopy to rule out primary angle closure glaucoma and subtle signs of pseudoexfoliation and pigmentary glaucomas, and also the secondary glaucomas. So, and a systemic history of migraine, Raynaud's phenomena, episodes of shock, headache, sleep apnea, and other neurological symptoms should be asked. And also history of excessive water drinking in morning and breath holding exercises. So use of medications, including systemic and inhalational steroids, which is pretty common, and beta blocker should also be taken into account. 24 hours blood pressure monitoring to exclude nocturnal systemic hypotension, and blood and investigations to rule out systemic etiology. MRI is not indicated in all, but it may be necessary to rule out intracranial space occupying lesions, especially in young patients who have neurological defects and disc pallor, and the discrepancy in the disc and field findings. One needs to rule out peripheral vascular diseases. Now coming to management, again, IOP reduction is the mainstay of treatment, and a 30% reduction is what is recommended. So PG analog are obviously the first choice, and if the IOP is not controlled, one can add brimonidine or dorzolamide, which are said to have neuroprotective and vasoprotective effect. But as such, the role of neuroprotection is not very clear. And however, one must identify and treat any cardiovascular or hematological disorders. And if the IOP is not controlled, if the patient is progressing, then one needs to resort to surgery. However, one needs to prevent hypotony in these patients. Although most of these patients do not progress at a very fast rate, so you need to identify whether the patient is progressing or it's a non-progressive patient. So to conclude, in normal tension glaucoma, consideration must be given to vascular factors, especially in progressive cases, and a detailed systemic history and evaluation has to be done to rule out systemic diseases. Controlling intraocular pressure remains the mainstay in management of NTG as of now. However, neuroprotective agents can theoretically improve the function of retinal ganglion cells and optic nerve, and thus these are the interesting areas of investigation for the treatment of normal tension glaucoma. Thank you very much for your kind attention.
Yeah, thank you, Sunita. It was a nice overview of normal tension glaucoma management. We'll keep the question answer in the end. Now I'll ask Shefali to talk about the overview about the newer drugs and nanotechnology before we go to our guest speaker. Shefali, please.
Yeah, thank you, Dr. Raghu and Ajanta, for giving me this opportunity. Are my slides visible? Are my slides visible?
Visible.
Yeah. So good evening, everybody. So I'm going to talk on the newer molecules to nanotechnology in glaucoma. So I think there are a lot of wonderful additions which are going to happen, or maybe already there are a few molecules which are already introduced in our market, and they are going to be wonderful additions in the current armamentarium of glaucoma management. So just a little bit about the glaucoma epidemiology. We know that at this point of time, 70 million people suffer from glaucoma, and the projected prevalence of glaucoma by 2040 is 110 million. So we have a huge backlog of glaucoma, and the current mainstay of treatment, we all know it's a ocular hypertensive medication at this point of time, and that to topical drop. Other options are lasers and surgical options. However, the mainstay of the treatment is topical drops, and they have their own limitations, like the problem of solubility, their reduced bioavailability, There is a problem of tissue irritation and the damage because of the presence of preservatives, reduced or limited shelf life, and also there is a problem of this number of the dosing schedules, the frequent dosing schedules, and also the amount of active drug which passes into the where the target site, that is also very limited. So there are a lot of limitations of these topical drops. And though we have number of new preservatives in the market, but one of the most commonly used preservative at this point of time is benzyl alkonium chloride. And we know it gives chronic, on a number of patients, we have seen that on chronic use, it gives chronic follicular conjunctivitis, and also congenital hyperemia is quite frequent issue, or is a common problem with the use of this medication which contains benzyl alkonium chloride. So now in glaucoma armamentarium, as I said, number of new molecules, either they have been introduced or they are in pipeline, and definitely they may be available in future. And some of them which I'm going to discuss are like newer molecules, fixed combination therapy, preservative-free technology, and newer drug delivery system. So newer molecules are ROCK inhibitors, which are letrozole and ripazole, which are already in the market. Then is latanoprostene bunod, trebedonosone, and omidinapeg isopropyl. So I'll discuss a little bit about this. The drugs, newer drugs, which are available now. Latanoprostene, which is actually the combination of PGF2 alpha and nitric oxide. And nitric oxide potentiates the cyclic GMP production, which acts on trabecular meshwork and Schlemm's canal. So basically, latanoprostene, which is it's a combination of this PGF2 alpha, which works on the uvascular outflow pathway, and nitric oxide, which works on the conventional pathway, that is on the trabecular meshwork. And studies have shown that this latanoprostene will not when it gives better, it has better IOP reduction compared to the latanoprostene 0.005%. ROCK kinase inhibitors or ROCK inhibitors, and where Dr. Deepak Edward is with us, and he is going to talk to us regarding this thing in detail. So I'm not going into it. Another is trebedonosone, which is a selective adenosine mimetic, and it augments the trabecular meshwork. However, the phase 3 trial have failed to show its efficacy over the placebo, so this may not be the option in near future. Another is omidinapeg isopropyl, which is a selective E2 receptor agonist, and again it works on both trabecular outflow and the vascular outflow. And the phase 2 randomized trial have shown its non-inferiority to latanoprost 0.005% in clinical trial, where primary endpoint was intraocular pressure reduction. Another, though we have fixed combination in market for a long time, but there are few new combinations which are available. One of them is letrozole with latanoprost, which is available as rocletan, and the other, but the more fascinating are the triple combination, though they are not available in our country, but they are available in other countries. And this triple combinations are with prostaglandin analog and beta blocker, along with the carbon anhydrase inhibitor or alpha-2 agonist. Now, the advantage of fixed combination is that because the number of the drops that is going into the eye is less, it becomes more patient friendly, and therefore the compliance and adherence of the patient improves. And also because the number of drops reduces, therefore the amount of the preservatives going into the eye is also less, and therefore the side effect because of the drops is also, the chances of that side effects is also less, is also minimized. Preservative-free technologies, unims, that are already there in India. Now we have one of the prostaglandin unims which is available. Another is Novelia technology, which is a multi-dose closing tip system, and it is bottled. So basically, it is not use and throw like unims, and because of its technology, it is preservative-free. Another very exciting development in the glaucoma management is the development of drug delivery system for nanotechnology. And the nanotechnology, this is a new technology. So I thought before I go into the detail regarding the role of nanotechnology in glaucoma, I will tell a little bit about what is nanotechnology, because it's quite a new branch. So what is nanoscience? It is basically the manipulation of materials at atomic, molecular, and macromolecular scale. And nanotechnologies it helps the system by controlling the shape and size at the nanometer scale. Now, to us, this nanotechnology may be new, but there was a recently published article is published that they have discovered some pottery from the state of Tamil Nadu, where there is a coating, the nanomaterial is coated on this pottery, and it dates back to 6th century before Christ. And this pottery, it still retains its stability and adhesion. So nanotechnology is basically a convergence of science and engineering, and it has helped medicine to work with increased efficacy, high bioavailability, and lesser toxicity. Now, just to put into perspective that how small the size is when we are talking about nanotechnology. Now, we know that red blood cells, it is 8 micron in size. And if you convert this 8 micron size into nanometer, then the size of the RBC becomes 8,000 nanometers. And in nanotechnology, what we are dealing is the size of 1 to 100 nanometers. So you can understand that in nanotechnology, this is very small or the minuscule size that we are dealing with, which is equivalent to the size of viruses and DNA. So what makes the nanotechnology different from macrotechnology? So basically the main difference is this particle size. Now, because of the smaller size of the particles in this nanotechnology, there is a greater surface area to the volume ratio, and therefore the capability of these molecules to be laden with these drug particles, it increases drastically. So more amount of drug can reach the target site, and also because of the smaller size, they can easily cross all the physical barriers of the body, and therefore the more amount of drug is able to reach the target site. And another important thing about the nanoparticles is that because of the smaller size, it changes the physical and chemical properties of this material. Just to give an example, like copper, if it is a macromolecule, it is opaque, but when it is the nanoparticle, it is a transparent. And even in nature, we see a lot of examples of nanotechnology. One of it is a butterfly wings, color of the wings of the butterfly. As we already discussed, so these are the modalities, and we mainstay is topical drops, which has its own limitation. So there comes the role or advantage of nanotechnology-based delivery system. So basically, it takes care of all the limitations of the ocular hypertensive medications, like it provides sustained release, better bioavailability, accurate dosing, little or negligible tissue irritation, longer shelf life, and better target delivery. This video which shows, I think this video is not working. It is basically on the tear film. You can see this is the nanoparticles which are laden with this drug, and they are so actively they are moving, which improves the permeability into the cornea. Therefore, thus the amount of drug reaching the target site is much more. I'm sorry, this video I'm not able to show. Then there are multiple nano delivery systems, and which actually can be used along with the contact lens also. And the type of the nano delivery system we choose depending on the drug type, target tissue, and the route of administration. Now, what is the role of nanotechnology in glaucoma? Now, at this point of time, a lot of research is going on, and a lot of research is going on the animal models, but also on the human. There are phase 1, phase 2, and phase 3 trials which are going on. So I'll be discussing few in this talk. This is the list of medications on which this research is going on regarding the nano drug delivery system. Then there are nano devices. Then it is IOP monitoring, neuroprotection and regeneration, which includes gene therapy and also regeneration of cellular meshwork. Now I'll discuss a little bit about these available drugs which are already in phase 2 and phase 3 trials. Now one is the latanoprost, where the comparative analysis between the commercially available Xelatan and the latanoprost loaded liposome is done, which was administered via the subconjunctival route. Now this you can see this blue line is with the commercially available latanoprost or Xelatan, and this red line is with the latanoprost loaded liposome. So on the first injection, on the first subconjunctival injection, the effect of this, it lasts for nearly 3 months, 3 to 4 months, and on the second injection, you can see the latanoprost loaded liposomes. the intraocular pressure efficacy is improving after the second injection, and it lasts for nearly 6 months. Similarly, research is going on regarding timolol molecule in vivo rabbit studies, where nanoparticles encapsulating timolol were researched. They've shown they are more effective in lowering IOP as compared to the commercially available drug solution. Also, the subconjunctival administration of microspheres encapsulating the drug have shown the sustained drug release for up to 3 months in vitro conditions. And recently, an enzyme-triggered release contact lens system was engineered for timolol delivery using nanodiamonds. Similarly, brimonidine inserts in vitro studies have shown better IOP lowering compared to the commercially available drops. Then combination drop, that is timolol and dorzolamide, is also being researched. Methazolamide, you can see this is blue line is the commercially available this methazolamide versus this methazolamide loaded with the nanoparticles. You can see it has much better efficacy, and also this effect lasts much longer compared to the commercially available methazolamide. Now, another exciting development is the development of nano drainage device. We know that one of the limitation of our GDD is the fibrosis, because of which the glaucoma drainage device fails and the pressure rises. So now we have the nano drainage device which is being under trial, which is being researched, where they are loaded with the mitomycin C and 5-fluorouracil, and there is a sustained delivery of 5-fluorouracil for up to, which starts on third to fifth day and continues up to 28th day. And also to address the issue of post-operative hypotony, their plug filters are embedded into it, which are polymers, so to prevent the post-operative hypotony. Pascalis et al. Designed a glaucoma valve that operates with ferrofluidic nanoparticles which have supramagnetic properties, and this ferrofluid acts as a valve maintaining the pressure between 7 to 10 millimeters of mercury, which is ideal. And just to show this how small these nano devices are, even less than 2 millimeter. You can compare it with the tip of the ball pen. These are so small nano devices. Then this is another prototype, this nano drainage implant, known as ND, which is actually the scleral implant. Then we have punctal plug delivery system, where the travoprost and latanoprost punctum plug for intraocular pressure reduction are under research, and the intracanalicular insert of travoprost, they have shown that effect lasts for up to 90 days without preservatives. In phase 3 clinical trial, the insert lowered IOP between 3.27 to 5.27 millimeters of mercury in patients with open angle and ocular hypertension. Similarly, we have latanoprost L-shaped punctal plug with latanoprost core, and in phase 2 clinical trial, this latanoprost punctal plug have shown 20% IOP lowering over 3 months with retention rate of 92%. Another, what we have already available, this is already in the market, not in the Indian market, but it is available now. This intracameral implant of this bimetoprost, known as Durista, which is a drug-eluting polymer, and it effects last for nearly 3 to 3.5 months. Another is the travoprost implant, which is actually replaced into the trabecular meshwork. It is known as glucose, and the phase 2 study have shown average 32 to 33% intraocular pressure reduction. And another important development is intraocular pressure monitoring devices. One of them is permanent implant IMate for continuous IPM monitoring, which is already under human clinical trials. And also another is contact lens, that is triggerfish, which has been done. New York protection, ultimately, and regeneration, trabecular meshwork regeneration are ultimate our hope and the future of glaucoma management. And this intravitreal injection of glial-derived neurotrophic factor have shown little bit hope, but however the research is quite preliminary stage, so still we need to wait for this. And so to conclude, there are a lot of newer options which are in horizon, and they have a potential to considerably increase the quality and efficacy of modern day glaucoma management. And they are definitely the future generation medicine and hope for the glaucoma patients. They improve bioavailability and ensure sustained target delivery, and it takes care of a lot of limitations of the topical ocular hypertensive medications. However, at this point of time, this branch is at its infantile stage, or it's a developing. So safety concerns, especially the nanotoxicity in the form of particle, excipient, contaminant, and inflammatory toxicity, needs to be addressed. Thank you very much.
Okay, thanks, Dr. Shefali, for the nice overview of nanotechnology. Now, I would request our guest speaker, Dr. Deepak, to start his talk. He's going to talk in great detail about the Netrasodil. Dr. Deepak, please.
Okay. Well, good evening to everybody in India, all distinguished colleagues, and I'd like to thank Ajanta Pharmaceuticals for inviting me to give this talk, and Dr. Parekh for his kind introduction. I truly enjoyed all the talks of my distinguished glaucoma colleagues in India, and thank you very much. So what I will be speaking to you today about is the role of Netrasodil in the management of glaucoma. So what I will be talking to you today about is an overview of ROCK inhibitors, how they work, some of the clinical trials data, safety and adverse events, and its use as adjunct therapy and some of the newer data available in this regard. So I'd like to start by paying tribute to Dr. David Epstein, who was actually the driving force behind developing Rho kinase inhibitors. Dr. Epstein was a glaucoma clinician scientist and chair of ophthalmology at the Department of Ophthalmology at Duke. He is also the person who not only discovered these ROCK inhibitor molecules, but took it from the lab to the clinic by founding ED Pharmaceuticals in the United States. And now the drug is clinically available for use to treat our glaucoma patients. I think the most important thing about Dr. Epstein is that brilliant as he was one of the most humble the clinicians and never afraid to say, I don't know. So I think I thought I'd spend a few seconds paying tribute to him. So if you look at glaucoma, and I'm going back to looking at some basics here, that aqueous is secreted from the ciliary processes, and there are really two ways that aqueous gets out of the eye. One is through the trabecular meshwork Schlemm's canal system, and the second is through a pressure-independent pathway into the uveous scleral flow. So we have drugs that work at the ciliary epithelial level. We have drugs that work in the uveous scleral outflow, and very few drugs that really address the trabecular pathway as we know it. The oldest one that we have and we know is pilocarpine till recently. Now, as you look at the trabecular meshwork, it's a very interesting structure in the sense that it has collagen beams, but has these trabecular endothelial cells which line the trabecular beams. And these beams are rich in actin filaments. So this is an immunohistochemical stain. The orange are the actin beams, and this is normal trabecular meshwork. And the picture to your right shows a glaucomatous trabecular meshwork, and you can see the actin fibers are increased and the cell is under stress. And that's one of the basic findings that you see in the glaucomatous trabecular meshwork is that actin filaments get coarser, they're at a great degree of stress. Now, if you look at ROCK inhibitors and how they lower IOP by targeting the trabecular meshwork, again, the key thing to remember is this is a drug which works at the level of the trabecular meshwork. So Netrasodil is the drug which I'm going to be talking about, is a Rho kinase inhibitor. So what Rho kinases do are that they increase cell contraction, as you saw in the trabecular meshwork. They also cause increase in extracellular matrix production in the trabecular outflow system. So when these cells are stressed, they do produce excessive extracellular matrix. The trabecular meshwork gets compact, and this extracellular matrix production plays a role in increased outflow resistance and therefore increased intraocular pressure. So the way Netrasodil, a ROCK inhibitor, works is by inhibiting ROCK inhibition. It causes a decrease in cell contraction, a decrease in extracellular matrix production, and improving trabecular outflow by these mechanisms. Another interesting mechanism that it works through is by decreasing, decreasing distal resistance by increasing the diameter of episcleral veins and by decreasing episcleral venous pressure, which is an interesting mechanism. So this diagram kind of shows you the pathways or the mechanistic pathways on how ROCK works and how it works on actin stress fiber assembly and adhesion and assembly of the stability of the actin fibers. Again, shown here in a different way, where you can see that the actin myosin fibers are present in the trabecular endothelial cells. There are focal adhesions to the extracellular matrix. Rho kinase molecules act at this level, and when they're activated, you have increased stress, increased TM contraction, and elevated IOP. Again, this work came out of Dr. Epstein's lab. So when you treat a patient with ROCK inhibitors, relaxes the TM cells, these focal adhesions are lost. Rho kinase inhibitors binds to the Rho kinase, results in decreased TM contraction and reduction in intraocular pressure, again by the trabecular endothelial outflow pathway. So I really like this slide from this study from investigative ophthalmology, and this is again a study done in donor eyes and not live, but you can see that on the top picture, you see trabecular meshwork in a control eye, very compact fibers in a donor eye. But when you put the drug natarsadil, you can see that the the spaces between the trabecular meshwork are expanded, and that is because of ROCK inhibition. There's less stress on the trabecular endothelial cells, and there's expansion of the trabecular meshwork, probably increased porosity in this area, especially in the juxtacanalicula tissue, and increased outflow of fluid from the trabecular meshwork to the Schlemm's canal. So here are some initial studies from a very well-respected group showing how trabecular outflow occurs and what the degree of lowering of trabecular outflow resistance you can expect. And you can see that from these various groups in clinical studies, they showed that there's approximately a 35 to 39% decrease in TM outflow facility, and it increases outflow in about 34% of increase in outflow facility is about 34%. So in glaucoma, you have approximately a 37 to 39% decrease in outflow facility. When you add natarsadil, you can see that there's an increase in outflow facility when you measure the outflow facility, suggesting that this drug truly works through the trabecular meshwork pathway. So here's a nice study. Again, Arthur Sitt, who is at the Mayo Clinic, presented this study, and I think it's in publication somewhere, where he used a special instrument to measure episcleral venous pressure. And he did this by putting patients on natarsadil, patients with POAG or ocular hypertension, and compared it to control. And he has a special slit lamp custom designed machine to measure the episcleral venous pressure, which is basically a bulb, and you can see the episcleral venous vessels through it. And if you increase the pressure and you measure the time of vein collapse. So with this, you can see there's approximately a 10% decrease in episcleral venous pressure when you have when you treat patients with this medication. So this has kind of a important implication. So if you recall that the outflow resistance comes from the trabecular meshwork and the and also the juxtacanalicular tissue, as well as the Schlemm's canal, but there is some resistance at the level of the episcleral venous pressure, which is around 10 to 12 millimeters, and that's why when you do mixed size procedures at the level of the Schlemm's canal, it's hard to get rid of the resistance from the epicyclical venous pressure side. So I think being able to lower epicyclical venous pressure probably has an added effect in lowering the intraocular pressure in glaucomatous eyes. Having said that, we've, on a clinical basis, tried these drugs on patients who have, clinically raised epicyclical venous pressure, on a patient with a low flow dural fistula, and also in a patient with Sturge-Weber syndrome. Again, this was the last drug added. We did have some lowering of intraocular pressure, but then on the other hand, it's very hard to dissect the effect of epicyclical venous pressure, the drug on the epicyclical venous pressure versus the trabecular outflow in a clinical situation. But it's nice to know that you have a drug that works on different systems. So how's Natarsadil, or Ropressa, as it's known in the United States, available? It's a 0.02% buffered aqueous solution of Natarsadil dimesylate. Remember, the pH is a little acidic, so patients do complain about a little stinging when they put the drop in the eye. And so these are, each ml contains about 0.2 milligrams of the medication. It does have preservative. Benzalkonium is the preservative that's there for this medication. And the interesting fact to remember is that it is a prodrug, and that it is converted to Natarsadil M1 by corneal esterases, very similar to how prostaglandins are converted by these corneal esterases when you put it on the surface of the eye. So coming to some of the clinical trial data, again, there are a number of clinical trials, phase 3 trials that have been published with Natarsadil, and these are all known by this acronym ROCKET, the 1, 2, 3, 4. The design is somewhat complicated, but what I'm going to just summarize it. All these studies used Natarsadil first twice a day and the later once a day at nighttime, and compared it to timolol twice a day. The FDA uses timolol as quote unquote the gold standard, and this was a non-inferiority design randomized clinical trial. So all the patients were washed out of the medication, and the ROCKET 1, 2, 3 had IOPs between 20 to 27 at recruitment. ROCKET 4 went to up to 30 millimeters of mercury in their recruitment. ROCKET 1 reported drug outcomes at 3 months, ROCKET 4 at 6 months, and a combination ROCKET 2, 3 gave us results at 12 months. So the primary endpoints were, of course, measurement of IOP in a diurnal fashion at baseline, as well as out into the study, and also the safety and adverse events were reported. So here are some of the results. IOP at baseline in the mid-20s, and then here you see IOP lowering effects. The blue is Natarsadil, and the green is timolol. And you can see, of course, there's IOP lowering. There's no flattening of the diurnal curve, but you can see there's about a 4 to 6 millimeter drop in intraocular pressure. And these results showed that the drug was non-inferior to timolol. So if you look at it another way, looking at all the combined the results of ROCKET 2 in 129 patients, you see a baseline of IOP of about 22.5 and a drop of intraocular pressure to approximately 17 to 18 millimeters of mercury on average using this drug once a day in the evening. So these are the side effect profile, again, pooled data, and the incidence was, which was kind of reported for various things. So conjunctival hyperemia, presence of corneal verticillata, subconjunctival hemorrhage probably were on the top of the list. So I can tell you from clinical experience, you do have hyperemia. I have been right now, because of it's an expensive drug in the United States right now, and not many insurances have approved it as a first-line therapy, but that is improving as time is going on. The hyperemia most often is very much like what you get with latanoprost. And if for those of us old enough in the audience would remember in the late 90s and the early 2000s when the prostaglandins were first introduced in the market, there was a lot of discussion and a lot of hype about the hyperemia that's kind of drawn down. So you do get some hyperemia. Patients usually don't complain about it. Yeah, you notice it in the office. You do have this interesting finding of corneal deposits, which you see they're not visually significant. I probably have seen one patient with a spontaneous subconjunctival hemorrhage, and there are some other corneal findings that are there. I'll show you some pictures, which are fairly rare. So here's a patient of mine with corneal verticillata that we saw recently. Again, deposits that are there in the cornea. These are supposed to be lipid-related deposits in vesicles in the corneal epithelium. They go away if you stop the drug, but again, they really don't cause any trouble. They look very much like the deposits you see on patients on amiodarone for heart problems. Now, another finding that has been reported is reticular epithelial edema in patients. And this is an example from a paper a couple of years ago, and there have been several case reports recently. And these are corneal edema in patients. And these are typically patients who are at risk for developing corneal edema. So patients with severe Fuchs endothelial dystrophy, mildly decompensated corneas from bullous keratopathy type lesions, patients who undergone transplants. Those are the patients who are at risk of developing this interesting corneal edema. Again, it's reversible once you stop it. Often the first sign that patients complain of is that they complain of fluctuating vision a few minutes after putting in the drop, and that gets better later in the morning after they get up. Now, there have been recent studies looking at post hoc analysis of these patients and the effect on corneal endothelium and central corneal thickness. To summarize, again, this is the study using where rocklatan was compared to Ropressa, which is rocklatan being the combination of nitarsodil and latanoprost. There's no effect on the corneal endothelium. Interestingly, the central corneal thickness was decreased in the fixed combination group by about 6 microns, and then nitarsodil group by about 3 microns, and the latanoprost by about 1.2 microns. The mechanisms are interesting and might be related to the corneal esterases that might be activated, but we really don't understand the mechanism by how these corneas become slightly thinner when you put them on these medications. So here's results of another study on nitarsodil. Again, this is not, I don't think it's published yet, but this shows the effect of nitarsodil as a more of a combination therapy or an adjunct therapy, and as well as some data from real world setting. So the design of the study, again, they had patients where nitarsodil was used as monotherapy in green or as adjunctive therapy to other medications, and they looked at patients for about 12 weeks to see the effect of the medication. So here you can see that when you have nitarsodil with a PGA combination, and this is the mean IOP, and you see about a 5% reduction with 5-point reduction with the addition of PGA. And we know this well from the use of rocklatan, a pretty powerful medication. When you combine these two drugs, you get a really whopping lowering of IOP by using these two medications. Here, interestingly, where you had addition of nitarsodil when patients are already on 2 adjunctive medications, which was a variety of combinations. And then when you add nitarsodil, you again get a 3 to 4 point drop in approximately a 4-point drop in intraocular pressure by adding this other medication. This sort of is not surprising because you do have a drug now that works on the trabecular outflow pathway, and then also on reducing episteal venous pressure. So in this study, again, if you look at it another way, to see how many percent, what percent of patients drop the intraocular pressure to what level. So I'm just going to concentrate on this particular number because, as glaucoma specialists, we see advanced glaucomas. We often want medications that can lower the pressure to the mid-teens or low teens. So you can actually achieve about, by adding this as an adjunct therapy to at least 2 medications, about 40% of patients, you can achieve a pressure of less than 15 by adding this medication onto as an adjunct therapy. So the adverse events on this study, interestingly, again, this is a real world study. The conjunctival hyperemia was much less reported. Vision blurring was less, and subconjunctival hemorrhages were seen in only 5% of patients. And some pain on instillation, like I said, is because I think of the acidic material that is acidic, the pH of the medication. Oops, sorry. So this is the patient-reported tolerance, that about 89% of patients reported that nitarsodil was tolerated well, and about 70% of patients rated patient acceptance as good or excellent. So a fairly well-tolerated drug. It does have some issues, but overall it's generally very well tolerated and accepted by patients. So this is a study we did, one of our fellows, Amy Mehta, who now practices in New York, and we presented this last year at the American Glaucoma Society. Well, I guess this year before hell broke out in the pandemic. So this was from a research consortium that we created, looking at real-world use as Repressa or nitarsodil in refractory glaucoma patients. And now glaucoma specialists always see this, and patients sometimes don't want surgery, or for whatever reason, we want something else to lower the intraocular pressure. So inclusion criteria was that we needed, this was a retrospective data from several centers, and we looked at outcomes of mean point reduction, percentage reduction from baseline, and change in visual acuity. We defined responders to decrease in IOP at any degree, and non-responders to no change in IOP, and also recorded adverse events and analyzed the data. So here's a very busy slide. We had about 134 patients, and you can see we had number of eyes, about 54 on 2 medications and about 48 on 3 medications already. So we were adding, the group was adding Repressa as a 3rd or 4th drug in a large majority of patients. And here is the change in IOP that mean change in IOP was about 3.53 millimeters, similar to the MOST trial that you got, in addition to the other medications that people were using. The reduction was approximately 15% reduction in IOP, and about 12 out of 98 patients, the medication was either stopped for adverse events or non-response. And they were followed for an average of 2 months approximately. So if you looked at the data in a different way, this is the Repressa group, and this is the amount of IOP lowering. So most often you get about a 3 to 4 millimeter IOP drop when we add the drug. So the interesting thing was that we did see a lot of variance, but it didn't matter whether they were on 2 drugs or 3 drugs. The IOP lowering was on the average approximately 3 to 3.5 millimeters. We had approximately 10 quote-unquote non-responders, and again, being retrospective data, we don't know if this was due to compliance or real non-response or real-world studies. So the bottom line, our conclusion was that it can be very, very useful as an adjunct therapy at this point in time, definitely. So to summarize, we know that we have a new drug, a new kid on the block that lowers intraocular pressure using a pathway that is the most important in glaucoma. And what I like about it is that not only it reduces, relaxes the meshwork, but also decreases the fibrosis, because when you relax the trabecular meshwork endothelial cells, there is less extracellular matrix production, and therefore it might, quote unquote, protect the meshwork from getting to a more severe stage of damage. It, of course, also decreases epicardial venous pressure. And the phase 3 trials have shown that it is quite efficacious. You do get a, like I said, anywhere between a 4 to 5 millimeter drop in intraocular pressure. It works well as an adjunct therapy to a patient's regimen. So a real blessing to us glaucoma specialists to have another medication that we can add on. And the efficacy seems to be stable for, at least in the clinical trials, to approximately 12 months. As I said before, conjunctival hyperemia was the most frequently observed reported effect. It's mild. The patients that I have them on, really, most of them don't complain about it. And you do see these interesting other side effects of the medications not seen by other medicines, and most of them tolerate it. So it's good to have this new addition to our armamentarium to treat glaucoma in 2020. So that ends my talk. Thank you so much for giving me the opportunity to talk, and I'm sure there are questions, and I'll be happy to answer them. Thank you.
Thanks, Dr. Deepak. You covered in in great detail everything, but there are some questions definitely. So we have one more talk to go, Manish's talk, and then I will ask the questions. The audience has asked lots of questions, so we'll discuss that. Before that, Manish will talk about the angle closure glaucoma. We know angle closure is a huge problem in Indian subcontinent. So Manish, will you take over?
Thank you, Rajul, and that was a lovely talk, Dr. Deepak. And I am going to go a little off from where we have been talking to a very basic talk, because I've always seen in these meetings that we always share a lot of data, and it is all regarding studies and all being done, but very important points, the message doesn't get carried over. There are two main types of primary glaucomas that we are treating: open angle versus angle closure. So are they really different? Because the same drugs are being used. Aim of the treatment is, it is always the first with medicines, and if not enough, then you do trabeculectomy, and you're going to monitor the progress by doing visual fields and optic disc evaluations and imaging. So you are going to do more or less the same thing. So are they really different? But that's where you should stop, because they are essentially very different diseases. And this kind of overall thinking that you're going to reduce pressure and monitor the disc and field for progression, and if drugs don't work, you're going to do surgery, is not as a too simplistic way of thinking, because these two diseases have a very different natural course and progression rates, especially in our country, where angle closure incidence is much higher than in Caucasians and in the Western world. And the amount of people going blind because of angle closure percentages are far more than in open angle. Secondly, angle closure disease presents generally a little earlier, and if not treated appropriately, can rapidly progress to vision loss and permanent disability. So you will have a situation where pressures are about 21 and no disc and field changes. And if you are not careful, you are going to use the vast amount of data which is available to us because of the OHTS trial, and it's been talked about in so many meetings, and you will say no disc, no field changes, just pressure a little bit higher. This is ocular hypertensive, risk factors are not there, corneal thickness is normal, or it is on the thicker side, and I am going to observe this patient. If you are not careful, you're going to miss angle closure, and that's going to behave very differently from the subgroup which was described in the OHTS. Just doing a simple laser can significantly alter the course of the disease and save vision in a vast amount of patients. There is a lot of talk about lens extraction, which may play a significant role, but yet we don't have that clear guidelines on when we should go for a clear lens extraction. And at this point in time, I don't think the data available to us warrants going for clear lens extractions. However, if there is a cataract, especially a significant cataract, that may be a different course completely. So identifying angle closure is the key, and every patient you have to look with suspicion of angle closure. Of course, gonioscopy and imaging technology is there for us to help us, but the simplest test which you can do even in the busiest OPD is have a von Herrick test, and there have been studies to show that it is a good guide. The basic way it is done is to make a small wedge of from your slit lamp and put it on the peripheral cornea and compare the cornea, peripheral corneal thickness with the clear area seen in the anterior chamber. And if this is significantly less, about 1/4, then you know that this is probably an angle closure. And if it is like this in this slide, you know that it is a deep chamber and angle closure is less likely. However, if you are meticulous enough, you should go in for doing gonioscopy, because gonioscopy is the cornerstone of managing angle closure disease. Imaging technology can be used as an adjuvant, but never as the primary method. And there is a trend these days in clinical practice, which I am seeing, is that since OCT is used for imaging the optic nerve head, and the OCT has a tool of doing the anterior segment imaging as well, it's very easy to, in the same sitting, do the imaging of the optic disc as well as macula and the angle and say, yes, we have looked for angle closure. But I would like to point out that the imaging system can miss angle closure, and you cannot evaluate so many points, which I'm going to share now, with an imaging technology, which you can with gonioscopy. So I'm going to skip this. You know, there are many types of gonioscopy lens, basically those who need coupling agents and those which don't. And you can do indentation gonioscopy with the Zeiss or the Posner or the Sussman type of lens. This is the picture, and these are the pictures of a normal anterior segment angle and the various structures you are going to see. It's very important that you follow a very regimented approach when you're doing gonioscopy. Initially, patient is going to look straight with dim lights, dimmer the better, and a very low height beam and a very narrow beam, so that not to impinge on the pupil and induce a pupillary constriction, which may change the picture of the angle. And the examination method has been taught in many talks, but I'll just go over. It's better to trace from anterior to posterior, from the Schwalbe's line down to the trabecular meshwork to ciliary body. In that way, you are less likely to miss structures instead of going the reverse way. And the curvature and insertion of iris is important. The basic question that we are going to see is, are there any abnormalities in the angle when you are doing the test? The essential part of the gonioscopy in every clinical exam, any examination for a patient you are going to do, gonioscopy should be a part of it. May be difficult in a busy OPD, and therefore it can be reserved in cases where you have even a little degree of suspicion. Definitely it is an art and requires some degree of skill, and that is where a lot of people seem to be having a problem. But if the surgeons are able to master so many other difficult surgical procedures, I think it can be mastered by all eye surgeons and not only glaucoma specialists. The information is very valuable in a variety of situations, but there are difficulties for beginners in holding the lens and getting folds. The folds are produced due to improper lens positioning, and you can learn how to manipulate the lens and get less folds, like a contact lens fitting. In very steep corneas or very flat corneas may be a problem. So this is the example of how you see the folds, and that destroys your visibility of the angle. In narrow angles, I would like to point out one very specific clinical situations where you get a false appearance of open angle because there is pigment which is little anterior to the trabecular meshwork, anterior to the Schwalbe's line, and the iris lens diaphragm is bulging in front, and you don't see angle structures, but you see the pigment which is there, and it often leads you to believe that the angle is open. So here you have a clinical picture of a gonioscopy, and you have the angle on the left. If you just see this angle and just look very cursorily at this pigment, you will think that this is an open angle until you do indentation and see that the iris moves fully back, and this heavily pigmented structure is actually the angle, and what you were seeing before is just anterior pigmentation anterior to the Schwalbe's line, and you have mistaken an angle closure patient for open angles, And this is the kind of mistake which I would like to warn everybody against, because you are going to really make a big mistake in treating this patient, which could be detrimental to the patient's final outcome as far as his vision is concerned. Sometimes you have very steep irises and they are actually open angles, but when you look at the iris plane, no angle structure is visible. You need to manipulate the mirror, and this is called looking over the hill. So if you are looking at the superior angle, you need to tilt the gonioscopy lens upwards, and then you will be able to see the over the hill into the angle. And this way you will miss again pseudo angle. Now you see over here, you are looking at the iris plane and no angle structure is visible. Lo and behold, you turn the mirror upwards and you can see that there is enough angle structure visible inside. So this is the view taken from a higher level, and this is the view taken at the iris plane. You can appreciate that. So this is a small video which shows you the same thing. First, we are looking along the iris plane, very bad. You can't see angle structures. You just tilt the mirror upwards, and there all the angle structures have become visible there. So this is the kind of thing which often you mistake open angles to be narrow angles. It is very important to do the gonioscopy with indentation and look if there is that angle closure is synechial or appositional, because that itself is going to make a difference in how you are going to manage the patients. The technique is used to push the lens back on the cornea while looking in the angle and keep it well opposed to see the effect. And then you can see whether the pressing of the lens is producing opening. Of course, you require some amount of patient's cooperation, and it has to be held continuously with gentle pressure while looking in the angle. So this is the example where you see the angle, no angle structure visible, but when you do the indentation procedure, you can see some amount of synechial there. There is pigment in the angle, and this is partially synechial angle closure. This is another example where you can see that some angle structures are visible, but with indentation, you can see better visibility of angle structures. And this is an example where you see synechial, and with indentation as well, nothing has changed. So this is total synechial closure. No difference is being made by indentation. This is a nice video which shows you the same thing, the same patient actually. You can see when you did the pressed, you can see the full angle opening. So indentation gonioscopy is a very important skill, and I would strongly recommend all eye surgeons to learn how to do this. Last and most important is, many times you see a patient and you see a pigment clump which is seen anterior to the iris, and sometimes big pigment clumps in the angle, and you see a little narrowing of the angle. It is not totally appositionally closed, but it is definitely narrow. And these kind of pigment clumps could be a sign of intermittent angle closure. So look carefully at all your patients, and with a very keen and suspicious eye for not missing angle closure before you decide on the treatment modality of your patient. And I would like to stress only on this point in this meeting today is, please do proper gonioscopy, and it's worthwhile for your patients if you can spend time and learn this technique. Thank you very much.
Yeah, thanks, Dr. Manish. This was very important because angle closure is very common in the Indian scenario. Now we have finished all the talks, and I have lots of questions. So the majority of the questions are on netrasudil. So I will ask Dr. Deepak. There are lots and lots of questions, Dr. Deepak, but I'll just enumerate because lots of questions are basically repetition. So okay. 3-4 questions. One, that whether have you used as a first line drug, or what is the role of netrasudil as a first line drug? The second, what is the role of netrasudil in angle closure disease? Third, whether we can give netrasudil in a traumatic, basically angle recession, or the traumatic glaucoma with hyphema.
Okay, all excellent questions. So the first question is that whether it can be used or have I used as a first line drug, and the answer is yes. The first line, very often we see patients in a tertiary care practice like ours where there is intolerance to multiple medications, right? And the patient is looking for another medicine. So that's been, and they're not on any drops. They're either ocular hypertensive or they don't want an SLT. So in those situations, I've used it as a first-line therapy. The main barrier to first-line therapy right now in the United States is the drug not being approved as first-line therapy on drug tiers and by insurance companies. It's pretty expensive if you buy it out of pocket. And that's the main barrier right now here in the US for people using it as first-line therapy. So in a limited group of patients, the answer is yes, we used it and it's worked quite well in those patients. Okay. The second question was, I guess, angle closure. Angle closure. And so, as you know, angle closure is relatively uncommon in the US, and I don't think there's any data. I personally don't have any experience with its use in angle closure glaucoma. It's an important, interesting question, because here you're talking about a disease where the angle is closed, right, by PAS, and the trabecular meshwork pathway is not that open. Whether this drug will work or not, it's an interesting question, and maybe this is something data needs to come out of India from on a topic like this. So I don't have an answer. Sorry.
Maybe the third was angle recession, traumatic glaucoma. Okay.
So I do not have actually. I do have experience, and is one. So we've had during the pandemic and the riots, we've had about 200 paintball injuries in Chicago in the last 5 months. You know, people have nothing to do. They've been shooting each other with paintballs, and we've seen a lot of angle recession. And we've had 2 patients who had sort of this acute form of angle recession, both young children in their teens, and the pressures were in the 40s. We added nitarsodil as a 4th or 3rd drug. It really didn't do much in those patients. So again, it's the same concept. We don't know the answer. So I guess if there are areas, and this is theoretical, if there are areas of the meshwork that are functioning, I guess it should work. But I don't have any clinical experience other than an extreme situation where we tried the medication.
I have a couple of questions on the same discussion. The one is that basically it reduces the episcleral venous pressure. So all the glaucomas where the dilated episcleral vein, will you consider this drug above the other molecules along with prostaglandin? Or
yeah, it's a good question. I mean, we've like I said, I've had limited experience, and we've had other colleagues around the US who use this in patients. The most common, think of as Sturge-Weber. Probably we see more of that than low flow, dural venous fistulas. And in my limited experience, we have seen a drop, but often these patients have come in with other medicines, and this was like a 3rd-line therapy or something before going to surgery. So you do see an effect, but it's hard to dissect the effect out, whether this is real. I mean, obviously, there is an effect on the episcleral venous pressure, but there's also an effect on the meshwork, correct? Whether, and very often, as all of you know, as glaucoma specialists, these are high-pressure glaucomas usually. They're not the ones that you see, right? The pressures in the low 20s, or often they're high-pressure glaucomas. So it is nice to have a drug available that can be added as an adjunct, or maybe tried as a primary therapy to lower intraocular pressure in these conditions. So I think we'll learn more with time, as the drug gets more easily available, and people who have large number of patients with these secondary forms of glaucoma will be able to test us and give us better answers. So that's my 2 cents worth.
Yeah, I'll come back to you with more questions. But sir, Dr. GC, I know since you were talking about the philosophy, the principle of glaucoma, the 2 things that I have 2 questions. Both are more or less on the same principle. People talk about the odds and EMGT and 1 millimeter, 10% benefit, and the AGs. AGs came and everybody said less than 12 is what we need. So I know, will you just clarify the situations for the, because we have nearly 1200 logins. So, it would be good if you clarify those both myth.
So each millimeter of mercury producing 10% reduction in progression rate, that's the relative risk reduction that they talk about. If you take the EMGT study, they had an average of 5 millimeter reduction of pressure. And if each millimeter reduced progression rates by 10%, they should have had a 50% reduction in progression. That's not what they had. So confusing between the absolute reduction and relative risk reduction, I think is the problem that happens there. So with 5 millimeter reduction, they had probably 15 to 16% of absolute risk reduction in the EMGT trial. So we need to, whenever people talk about risk reduction, it is the relative risk reduction they talk about, and the relative risk reduction is usually more impressive than absolute risk reduction, and that's what we need to keep in mind. The second question was about... pardon?
Please go ahead, sir.
No, what was the second question?
Second question was ages, the advanced glaucoma intervention study less than 12.
So the major thing that I have a problem with ages is that the report number 2 showed that a change of 4 units is considered as a significant progression. They graded visual field loss based on mean deviation and multiple other parameters from 0 to 20. And the report 2 showed that a change of 4 units is a significant reduction. And in all the data that they have, their y-axis is maximum 4, sometimes 3.5. So all the change that they are showing is only within that range. So an exaggerated y-axis, when you look at the data, is something that you need to be careful about. But having said that, the lower the intraocular pressure in patient that is progressing, the less is the progression rate, is what has been shown by multiple studies. How low is low and how safely can you get to that low pressure is a clinical judgment that needs to be made. Aiming for a 12 pressure for every patient of glaucoma and keep on adding medicines is probably futile, is what I would say.
Yeah.
Especially in the context of angle closure glaucoma or even primary open angle glaucoma that we see where patients present with a pressure of 35 to 40, even a 18 to 20 pressure there is a 50% reduction. So what's the amount of pressure reduction that you have got is what you need to see rather than just the absolute pressure, final pressure is my take.
Yeah. So the message is clear that IOP reduction is important, but beyond certain point, we have to be careful and not talk about 1 millimeter and start giving all sort of medications to every patient. We'll go to Sunita. You talk about the normalization glaucoma. How often you do the sleep study, or how often you see the obstructive sleep apnea patient?
How often? It's not, this is a newly recognized risk factor. And earlier we never used to ask history about, sleep, any kind of sleep disorder or difficulty in breathing during sleep. But now, since we know about this factor, which can cause obstruction during sleep, and this can lead to high intraocular pressure during sleep. When there is obstruction to the breathing, it could lead to high intraocular pressure also. So I think this factor should be kept in mind. And in patients who are slightly obese, I think this is a very important factor. And in India, I think it is quite common. So don't forget to ask the history of any kind of sleep disorder.
So Dr. Deepak, Dr. GC, want to add anything about sleep apnea?
Deepak, you want to go?
Okay, so I think I agree that you have a certain subset of patients. So you have two different interesting physical body habitus with normal pressure glaucoma. And one is, of course, what Dr. Sunita described. You have a slightly overweight person. They sit at your slit lamp, you pull the lid, it's floppy. And then you know that you need to really ask for a history of sleep apnea, and often it's positive. I think sleep apnea probably contributes to optic nerve damage in multiple ways. One, of course, is elevated pressure, but also hypoxia that it might create to the optic nerve with less perfusion. So it is, I guess, theoretically a modifiable factor. It's something you can do about it, unlike many other things like Raynaud's phenomena or low blood pressure, something you can modify. So I think it's important. Now, does modifying these factors actually make a difference? We don't know that yet, but I think sometimes when things make sense, you just do it, right? So it helps the patient, not only getting them better sleep, preventing them from other morbidities. Then you have a second habitus, which is also very common in the US, and the term used for that is the little old lady from Pasadena. So these are typically women who are very fit, they're tiny body habitus, they're very active physically. They also are usually avid exercisers. They have very low blood pressures. They have a history of migraine. And that's the second subset that we see. And that's fairly common. And these are the patients often have multiple disc hemorrhages that you see in these patients. So does it make a difference in the disease? Probably not. But I think it's an interesting feature that we see in these groups of patients and how they present at both extremes of body habitus and how these patients present with normal pressure glaucoma.
Okay. Shefali, you talk about the newer drugs and the nanotechnology. So my question is that we don't have ocular inserts available at this point in time in India, but the Durista has got FDA approval in USA, and once it's available in India, will you start giving, or will you shift your paradigm to the inserts from the drop, or what would you do in your practice?
Durista is definitely a wonderful addition. It's a very good drug delivery system. But at this point of time in India, even if it is available, first we need to see the cost, because cost is an important issue. Second, like if you ask me as a physician, I will prefer that rather than I will not prefer patient putting the drops and forgetting it, reduced compliance and side effects. But actually, there was a study which was published. I was just going through it few days back, and there was a patient survey which was done, and they preferred actually 80% of the patients preferred the drops, and that to the fixed combination drop. So maybe it is, I think, the patient, we have to respect what patient wants, or maybe patients are not aware of the new technologies now. So maybe once we start giving that option, patient may accept. But at this point of time, I think cost is an important issue. So if that is taken care of, then definitely I'll prefer it.
Dr. Deepak, you must have given few Durista, I'm sure.
So it's an interesting conversation about Durista. So I think, like I said, this is probably the beginning of intracameral, intravitreous type medication that will be available over the next several years. I guess one has to find the right patient, right, for this sort of medicine. That's number one, someone who would agree to put something in the anterior chamber. The second, of course, largest obstacle are two. One is approval from insurance companies. It is very expensive. Right now, $1,500 for one intracameral injection. So it needs pre-authorization and also from an insurance company, and as well as data to justify giving it. You have to fill out those forms. The second obstacle is really approved by the FDA for a one-time treatment, okay? The FDA approval is for one-time treatment, which kind of doesn't make sense right now, because how can you just give one injection, which might last several months? What do you do after that? Insurance companies will not pay for the second injection. So I think these hurdles need to be crossed before it'll have widespread use. Having said that, I've injected maybe two patients. Again, both had one had severe non-compliance, with medications and severe ocular, and the other one was intolerant to almost everything on the surface with severe ocular surface disease. Again, these were early glaucomas and mild glaucomas, both of the patients. So I think you're going to have to find the right patients, the right, what will happen in the future. I don't know the answer. But again, like I said, this is the beginning. Hopefully we have better drugs down the pipeline. As Dr. Sunitha pointed out, there's an interesting company at Hopkins that they've developed. It's called Graybug. You can look it up on the internet, which has this dendrimer nanotechnology. And they have several drugs that last for approximately 6 months. And these are injected in the vitreous and not in the anterior chamber.
Okay. Dr. Manish, you talk about the basics of angle closure. So, will you just very categorically talk about the imaging as opposed to gonioscopy in angle closure?
Basically, imaging technology has now come and a lot of people are using it. The biggest advantage of imaging technology, number one, is that documentation. Because you can really measure and document your findings very well. So that is one thing which I find the imaging technology useful. Second is biometrics, where actually you can measure the anterior chamber depth and the angle opening and everything and follow up the patients to see whether they are getting worse. So that is another point where I find the imaging technology useful. The third point where imaging technology can be useful is to measure the lens vault. So you have patients in whom the lens seems to play an important role in the angle closure mechanism, and using the imaging, you can calculate how much is the vault. And if the vault is significantly high, you can think of removing that lens, and that's likely to benefit that patient. But using the imaging technology as the only method of evaluating the angle is what I would strongly advise against. Because when you initially evaluate the patient, there is so much qualitative data which you get by doing a gonioscopy, as I showed in my talk, which is completely missed. So actually it appears that both are here and both need to be used. So they are complementary to each other rather than against each other. It is not imaging versus gonioscopy. It is imaging, it is gonioscopy with imaging. Coming in that order, that gonioscopy first and imaging second. So I think, does that answer your question?
So yeah, basically that gonioscopy is must. Imaging can add on gonioscopy, not replace gonioscopy. I think that message is good enough. We are running short of time. We had lots of questions, but everybody has a busy schedule and it's already 9:20. What I would request, Dr. GC, if you want to have any concluding remark, and then Dr. Deepak, and then we can close this session.
I think just to highlight some of the things that were discussed, sleep apnea, I think, is quite important in normal tension glaucoma workup. And we are seeing patients who are not even obese, but still have sleep apnea. And a couple of cases that actually were benefited by the CPAP and taking care of their sleep apnea. One point that we probably did not discuss generally is the tendency to treat the risk factors in isolation, because I've had patients who are put on treatment because their corneal thickness is low or because their imaging is bad, but there is no other parameter that is suggestive of glaucoma. So looking at the patient as a whole and putting all the findings together, I think is a very important thing. And as far as the corneal thickness and the intraocular pressure measurement is concerned, that we did not talk about, non-contact tonometry is something that NCT is something that should the no as far as decision making in glaucoma is concerned. And correcting the intraocular pressure, millimeter to micron corneal change thickness, is the other practice that I think should be stopped. It's not valid. Last point about the normal tension glaucoma probably is that the current literature of cardiologists are going very aggressively of keeping the systemic blood pressure very low. Somebody shared a recent article in American Heart Journal that talked about the risk for cardiovascular events increasing with a systolic pressure between 90 and 130. So even within the so-called normal systolic pressure of 130, If you bring it down lower, the cardiac events reduces what they're talking about, but they're not looking at the other risks to life and other cerebrovascular events and ischemic optic neuropathy and things like that. So that is something that we need to remember.
Yeah. So, actually, from your discussion, I remember that 1999 or 2000, the Journal of Glaucoma had an article. They had looked at the medical records from John Hopkins and surrounding area, and then nearly 20% of the patients, they could not find the reason to treat with the glaucoma medications. And I think the situation is still bad in across the world. So that your message is absolutely correct, sir. Absolutely. We have to categorize the risk factor and then decide that which patient require treatment. Not every patient, just because pressure is borderline or cornea is thin, require treatment. Absolutely. And Dr. Deepak, will you just?
Yeah, I just wanted to, all talks are really excellent, and I wanted to emphasize a point that Dr. GC made regarding visual field progression. Even in a very specialized tertiary center that's busy, fields can progress under your clock. And so sometimes we don't have, practices don't have, specialized software like the Forum software to look at everything in one shot, all the imaging, or have GPA analysis on their machine. I think it's a good practice, at least once a year or once every 2 years, to go back and look at the first visual field that you have in your office, you got for the patient. And sometimes you'll be surprised how field changes creep up on you. You typically like to take a look at the field the time before, and you see a decibel here or a decibel there, and you kind of say, well, nothing has changed. But when you go back and look at the one done 4 years ago, sometimes you'll be surprised. So now that we have other ways of getting specialized printouts and looking at a progression, it's nice. But if you don't make it a practice, and with EMRs, it's become easier. You can tag it to make sure, remind yourself to review the visual field. So there was an interesting study several years ago from the Mayo Clinic where they looked at their own patients, and they found that 8% of patients went blind at the Mayo Clinic being treated there. And these are, of course, patients who are very severe, but the main reason they went blind was that the doctors missed progression, the slow progression that happened over time. So I think that's a very important point, is A, to identify the fast progressors, but also to carefully evaluate the fields over time.
Can I ask a question, since we're talking about progression, just a small question? Like some patients do progress despite normal day diurnal. We do day diurnal in a lot of patients, but we are not able to do it in the night time. I had an opportunity to use contact lens sensor, which measured 24 hours intraocular pressure. And some of these patients did show nocturnal peak, although it is not a direct measurement, but it is a surrogate of IOP because it measures the changes of corneal curvature at the limbus. So between 12 to 4, although we always, like we have been taught that there's a morning peak in glaucoma patients, but I have observed, and in other studies also it has been shown that there's a night peak between 12 to 5 o'clock. So these patients do have a night peak. So what is your view about it? Because it's not possible to use contact lens sensor in every patient. It is very expensive and not available also. So
I think I would put it this way, that if a patient is progressing, unless proved otherwise, he requires surgery with the medication that is tolerating, especially if it's a primary surgery. The idea of doing a diurnal and looking at other systemic risk factors and things like that is to find an excuse for not doing the surgery. So if a patient is progressing, your threshold for surgery is very, very low. In case you find some other reason that may explain the progression, and you can buy some time to correct that and see whether you can stop progression or not, possibly more wishful thinking than this thing. But if the patient is progressing, unless proved otherwise, the patient is heading for surgery, is I think what we need to remember.
I would concur with that philosophy.
Okay. So I think we end the session. We had more than 1200 login. That is what the agenda people just sent me the message. I would thank Dr. Deepak, early morning to getting awake in Chicago and attending the webinar, and all the Dr. GC sir, Shefali, Manish, Sunita. There are lots of requests about the presentation, especially Dr. Deepak, Shefali, and Dr. GC sirs. I think Ajanta people have recorded, so I'll ask them to circulate the video. We can't give the presentation. I don't think the speaker will agree, but they can go through the video and make the note of the presentation. I would like all the speakers and the Ajanta people and all the audience who attended in such a great number. It was a wonderful session. Thanks a lot. Manoj, you can ask the backend team to
Sure,
a
sir.
very,
And before,
a,
sir,
a very,
before we end, I would request our India business head, Mr. Porus.
Yeah, sure, Dr. Porus. Go ahead.
doctors, please be logged in for another just 2 more minutes. At the outset, on behalf of Ajanta Pharma, I express our sincere thanks and heartfelt gratitude to our renowned keynote speakers, Dr. Edward and Dr. G. Chandrasekhar. I also thank our distinguished moderator, Dr. Rajul Parikh, who wonderfully moderated the session. Thanks also to our other speakers and panelists, Dr. Manisha, Dr. Sunita Dubey, and Dr. Shefali Parikh. We felt this summit was a tremendous value add overall for ophthalmology and to understand the paradigm shift in glaucoma management with a focus on Netar-Sudil. I also thank all our delegates for sparing your valuable time for the Netalo launch webinar and my team for organizing it well. Doctors, as you all know, Ajanta Pharma is an Indian multinational company which is ranked number 2 in ophthalmology in India. We are a forefront player in ophthalmology, which is demonstrated through our continuous innovation and ability to launch first time in India molecules. In fact, in the last decade, you would observe that around 80% of all the new products in ophthalmology were launched first by Ajanta Pharma, be it brinzolamide, bipotastin, alcaftidin, hypoclin, ripasudil, and many more. And now again, we bring for the first time in India, US FDA approved Netar-Sudil under the brand name Netalo. This has been possible due to the research and innovation vision of our joint managing director, Mr. Rajesh Agarwal, to bring the best of international products with world-class quality at an affordable price in India. I'm happy to share that we have 7 world-class manufacturing plants in India and abroad, some of which are US FDA approved. Ajanta Pharma distinguishes itself with a strong R&D thrust with state-of-the-art manufacturing, state-of-the-art R&D facilities involving more than 750 scientists. We have a strong presence in over 40 countries across the globe, including the most regulated market, United States, with an overall team size of greater than 7,000 representing 28 nationalities. While we are a major player in ophthalmology in India, we also have a strong presence in cardio, derma, pain segments as well. Among the various accolades over the last few years, Ajanta was recognized among the Fortune 500 companies across the sectors. All of this has been possible because of your contribution and association over the years, doctors from India and abroad. And we are very privileged to be associated. We look forward for your valuable recognition to this new launch Netalo, which has been launched at a highly affordable price. I did hear Dr. Edward talking about quite an expensive price in the United States, but in India, we've launched it at rupees 445 for a while. I'm sure this would be highly affordable for the patients. My team has ensured maximum availability to ensure each and every prescription of yours gets honored at all places across the country, and we await your valuable experience with the same. Once again, thanking each one of you from the core of my heart and commit for more such vibrant academic programs in the future. Stay healthy, stay safe, and wish you a happy new year well in advance. Thank you very much and have a good night. Thank you.
Thank you, sir. Thank you.
Thanks, everyone. Good seeing you, Deepak. Good day.
you as well.
We're offline
Yes,
now?
absolutely.
Amit, we are offline?